So as for our announcements, our MISTIE 3 mobile app survey is here. If you have not received it, please let me know. Otherwise, it was emailed to you probably last week or the week before. We want you to help us understand how the MISTIE 3 smartphone app helped you during the trial. We are asking for 100% compliance, and that would be coming from our MISTIE 3 PIs, coordinators, lead neurosurgeons, and our pharmacists. And then we also ask you to forward the survey to as many of your MISTIE 3 helpers as you can. If you've had extra dosing personnel or even the ER physicians, if they happen to have used it, or any other additional care team and follow-up members. And again, if you have any questions, you can email me. If you haven't received it, let me know. We are trying our best. I think we've sent it out to over 200 of you guys at this point, but if I've missed anyone, like I said, just let me know. Also, we are still working on shipping our Clear 3 trial site data to you. So again, if you have any questions regarding that, please contact me. I will, if I haven't already, I will be reaching out to you just to make sure addresses are the same. Unfortunately, it was a year ago at this point that I got your updated addresses, so I just kind of want to touch base with everyone and make sure I'm shipping these to the right spot. Also, to review our incentive program that we had from May until the end of enrollment, these are our big winners who worked hard for cookies and treats and gift baskets and coffee. So we had 26 sites overall, and as you see here, Washington University and University of Michigan had 3 enrollments. 2 enrollments came from New Mexico, Pittsburgh, Paige, Hopkins, Yale, and Intermountain and Southampton. So congratulations to all of our winners overall. And if you haven't received your gifts, make sure you contact your site manager or someone to make sure that you do get those. And some of our sites with their treats. We are still accepting pictures as well, if you wanted to send them. Okay, and with a tear in my eye, we talk about our last time we will talk about recent enrollment. So congratulations to Dr. Carrasco and his coordinator, Inigo, at Cruces in Spain. They enrolled their 5th subject on August 3rd, and this was our 504th enrollment. Congratulations to Dr. Jean-Louis Caron and his coordinator, Esther, at the University of Texas in San Antonio. They enrolled their 24th subject on August 9th, and they remained our highest enrolling site overall with 24 enrollments. And last but not least, we congratulate Dr. Michael Derringer and his coordinator, Michelle Allen, at WashU. They enrolled their 12th subject on August 15th. That was our 506th and final enrollment in the MISTIE 3 trial. So congratulations to all of you. And one of my favorite slides just shows that July really gave us the boost that we needed to, including when the MISTIE 3 expansion, and then August. We just needed those 3, which we got by mid-month, and now we're done. And for our coordinator of the month, we once again want to thank our coordinators of the month, to absolutely every single one of you, to helping us reach our goal and reach it early with our close of enrollment. So great job. All right, and with that, I'm going to pass things over to Hassan.
Hello, everyone. My name is Hassan Ali, and before I start, I just wanted to make a note about that mobile app survey. It only takes 5 minutes. That's the estimated time that's been noted on SurveyMonkey for each participant. That's been the average time. So it's really easy. It doesn't take much research on your end. Don't need to really reference anything, and the information will be really, really helpful for our team here. And I said this joke earlier this morning, ladies and gentlemen, we are not in an airplane. This is just the sound of the reading center. So please excuse the background noise if you hear it. And today I'll be talking about BIONIC. BIONIC is the acronym that we use to describe what is called colloquially, at least around here, as the reading center. So I'm just going to give you guys a brief introduction and a demo actually into kind of what we do here, the basics of it at least, and kind of the utility of the data that we inevitably obtain from the image processing software and segmentation performed here. So what is Bionic? So it's the Brain Injury Outcomes Neuroimaging Center, or the Reading Center, and it's a part of BIOS where we inventory and analyze all of the neuroimaging that we receive from the several large clinical trials coordinated here at BIOS. We have 3, sometimes 4 full-time specially trained readers. I'm a research program supervisor of the Reading Center at the moment, but we also have periodic research fellows from around the world. We have summer internship programs for undergraduate students, medical students, and visiting international students. And the trials that we manage go beyond MISTIE. I'm sure that you guys are familiar with CLEAR. CLEAR 3 was a 500-patient multi-center international clinical trial that looked at the treatment of IVH with alteplase. But the clinical trial resume for BIOS goes beyond simply hemorrhagic stroke and intracranial hemorrhage. We have, while ICES was within that realm, we also have READ-TBI, VIA-HEAD 3, which are both traumatic brain injury trials where our reading center served as a gold standard for a medical device that was looking into an EEG-based biomarker for functional brain injury and seeing whether or not their signals could pick up visible structural brain injury. So we have a skill set that simply goes beyond intracranial hemorrhage as well. And we also work with the VERT and InfraScan. And I'll stop here and just say, if you guys have any questions, if you guys have any notes or want to raise your hand or ask any questions, please do so. We can do it dynamically. You don't have to wait until the end. You can feel free to stop me at any time. And the Reading Center here, we specialize in hemorrhage identification and segmentation. So this is kind of what the Reading Centers look like over time. Dan started BIOS around 95, or at least the Reading Center's remnants, or has its nascency in 1995. And back then, we used to look at CT scans on these really old workstations, which allowed us, until 2000, to look at about 500 films. Then we moved to floppy disks, which allowed us to catalog about 1,500 scans. And if you look at that image in the upper right-hand corner, you can see kind of how technology has transformed over this period of time. We went from, I don't know how many floppy disks he has in his hand, but 132 megabytes to a multiplication of 1,000, a magnitude of 1,000 larger, to 120 gigabytes in the simple flash drive there. And we've also adjusted with the times. From 2005 on, we have over 10,000 scans from all these clinical trials and data analysis that we perform on these images that on an external hard drive and a server that now takes up approximately 9.8 terabytes. So a lot of data, a lot of imaging, and a lot of work that's been done here. So what do we do with the DICOM files that we receive? First of all, we download them. We download the inventory, and we also anonymize the images to strip out the PHI so that we have a version of both the source files in addition to the anonymized files we then use for research purposes and for steady endpoint specific radiological variable analysis that we inevitably, as you can see in the bottom left-hand corner, which we inevitably enter into the ECRF, as you can see on the right. I'm sure you guys are very familiar with this form of the EDC, but a lot of this work is also performed at the Reading Center. So again, we perform a mix of manual and threshold-based planimetry using OSARIX. When we say volumetrics, that's kind of what we mean. OSARIX is very accurate, and I'm actually going to be showing you guys a demo of it pretty soon, but it's very accurate and reliable across all types of hemorrhage, whether it be intraparenchymal, intraventricular, epidural, subdural, or subarachnoid hemorrhage. So any questions before we go to the demo? See any? So this is OSARIX. It's an image processing software. It's Mac only. I think the only closest analog would be Radiant, but OSARIX is kind of blows away the field when it comes to its capabilities from an image analysis standpoint. It's also a free software, although we have OSARIX MD, which costs a little bit more, but we were getting away with the simple version of OSARIX for a very long time until now. So here you can see an image that I pulled up here. of a patient, 6152, PHI stripped. I'm able to scroll through the entire image rather easily. I have information about the thickness, the pixel value or Hounsfield unit value in the upper left-hand corner. And yeah, this is kind of the viewer point here. What I'm going to do is show you guys how easy it is to segment an ICH so that you guys can potentially consider incorporating it within your clinical practice, because while this may seem difficult at first, it may seem complex, and may seem as if there's a large learning curve, once conquered, it's something that can be very easy and a very cool tool, I believe, for any physician or coordinating team. So here we have a left putamenal ICH, classic MISTIE patient, and let's segment this. So in the upper right-hand corner, I'm going to utilize the semi-automated growing region tool in Osiris, which allows us to place a bounded region around any part of the CT scans that meet our parameters, which are lower and upper thresholds of Hounsfield units. So hemorrhage has been established to be to have a lower threshold of approximately 40 to an upper threshold of approximately 100. However, I'm sure from your clinical practice that you guys know that 40 is kind of a high lower threshold to have for hemorrhage, whether it's hemorrhage on its way to clotting or hemorrhage on its way out. Blood can get down to 33. That's not totally unusual. We know the soft tissue is anywhere from 25 to 35 anyway. So it's really the technical ability of being able to discern hemorrhage from soft tissue and utilizing that 35 threshold that comes into play here. But it's pretty 40 to 100 is pretty good. Here I have a hemorrhage here. What I'm going to do is use a polygon ROI, which is going to be essentially a stencil tool. It's going to bound a region of the Hounsfield unit range that I establish. I'm going to place the lower threshold to be 38 Hounsfield units, upper threshold 100 again in the upper left-hand corner. You can see the pixel value. So this pixel value is 71 Hounsfield units in this area right here. So you can kind of see. Upper threshold 100. I'm going to name my ROI. Name ICH, and I'm going to click here, and you can see what how well SARX segments is simple ICH, and I'm going to kind of do that for the rest of the image. You guys can see how good of a job 38 Hounsfield units are. The ABC over 2 for this specific patient is 31, so let's see what we get. So on this image here, you can see that the bounded region established by the growing ROI isn't perfect, and it's not uncommon, and that's kind of how the manual part of this kind of comes into play. So what we can do is with this R tool or pulsar tool, is edit any kind of polygon ROI that I can draw at all. So going back to the ROI that I have, I can go and push out the bounds of the polygon ROI to incorporate that part of the hemorrhage. And as you guys can kind of see, I was able to segment this entire ICH in 3 minutes. Shorter than that?
1 minute.
1 minute. So there's also an upper right-hand corner. We have an ROI. ROI stands for a region of interest, which is essentially a description of the bounded region tool that that's kind of appearing on the screen here. If I go to the upper right-hand corner, it gives me some information about the ROI, and including the area on that specific image, in addition to the total volume. And you guys can see we have a volume of 26.4, and that's the volume for the ROI with that same name. So this is ICH. I'll show you briefly how we would segment edema. It's a somewhat dissimilar process. So on this image here, what we like to do is draw with the D tool, manual drawing tool, try to circle the perihematomal region of the ICH on each slice. I'm not going to do the whole image just to describe it for you guys. I'll just describe the process. So what we would do is do the same for each of the images with the ICH present. Try to include some soft tissue around it as well, which will allow our growing region to work a little bit better. And what the next step is to help improve our growing region and its ability to do its job. And the first step there is to change the pixel value of all of the ROIs that are outside of our bounded region. So what we can do here, so pixel value, i.e. Hounsfield units. So what we'll do here is establish that everything outside of this bounded region will have a Hounsfield unit that has a negative value. Excuse me, that's a user error. It's not an SARX error. although it's happened 2 straight presentations, so it's okay. So, okay, it's happening again. This doesn't normally happen. I'm not sure why that keeps happening. Okay, gonna keep occurring. Okay, well, let's imagine. Why is this happening? Okay, great. So yeah, this is what was supposed to happen those 3 times that I tried to do the same exact step. And you'll see that the outside of this region is at a negative value now. We're at a negative 1,000, while the house unit ranges within the boundary region are still preserved. And what we'll do is we'll use a growing region, but we'll use a different type of RY. It's a brush RY. It appears it doesn't look like the polygon RY, which is the one that we use to draw the outside region, but it appears brush-like, as you'll soon see. But it's truer to the pixel value, so it'll kind of include all of the areas of the part of the scan that I established. It'll include all the pixels that in the range that I like. So for edema, the threshold's a little different. If you guys, I'll have a reference at the end of this presentation. Andrew's work on MISTIE 2 established an edema range, house unit range, at least of 5 to 33. And that's kind of our starting point. You'll see that a lot of the stuff on the growing region is the same, although then I selected brush RY. And when I click here, you see that the brush RY appears different. It's very different from the polygon RY, and it's including parts of and I have the same slice to the right. It's including parts of the scan that I don't believe to be edema. I don't believe a lot of this to be edema. And what's nice is that we don't need to we don't have to keep that segmentation. We can adjust the house unit range to adjust for that. Okay, and I'm at 26 now, and I like that. I think it looks pretty good. I'll throw that lower threshold down to 5, and I press compute. And I can do this. I can just simply click, and the volumes merge with one another. So they'll all have the same name. I'm pressing compute here, and I'm clicking on and including all of the aspects of the edema that I believe, or rather, I'm including all aspects of this slice that I believe to be edema, and I'm constantly cross-referencing the slice with the image to the right of it. And I will do that for the entirety of the scan, but at the same time, I'm not going to do that. So that's kind of a sneak peek or a little view of kind of how we segment edema here. So the next question, as we go back to the presentation, does anyone have any questions, by the way? No, I'm not seeing any. So what do we do with this data? Why is this helpful? What are all these colors and how does it help us? So this first example is how Osiris volumetrics and segmentation can help us during the screening phase and overall help, and has overall helped our trial immensely. And you'll see here that we have a diagnostic scan and a stability scan of a patient above and below, where the ABC over 2 volumes do not reflect a true 30 cc expansion that was seen using Osiris. So the ABC over 2 for the diagnostic CT scan was at 95.4, while our reading center, or RC, Osiris-based segmentation had a volume of 73.6. And on the stability scan, which is below, the ABC over 2 was 96.7, so 1.3 cc increase, but the true volume using Osiris displayed a 30 cc increase. And these arrows are kind of areas of expansion, and this slide kind of drops on the point of the utility that Osiris can have for your clinical practice, and the utility and the ease, and how the ease of the application itself in segmenting hematoma can really have important and immense effects on your patients and outcomes themselves. So again, what do we do with this data that we obtained from the trials? This is from the MISTIE 2 paper. I'm sure you guys are familiar with this. And on the left, we have a graph depicting ICH volume remaining percentage. So the red is the minimally invasive surgery plus RTPA group compared to the medical group. And you'll see that over 4 days, which is the average treatment time for the medical, and the 4-day period of time was the average duration of the treatment time for the surgical patients, we see the 60% reduction in an ICH volume, whereas in the medical group, we don't really see much at all. And you'll see that the 50% percentile of the patients in the surgical group saw a 22 cc reduction in ICH overall, whereas the medical group at 50 percentile, approximately 1 cc. So this is kind of how the data makes its way from ASARS into the clinical world and clinical research. This is a chart. This is from the perihematoral edema publication by Andrew that was heavily based on the edema segmentation that I showed you guys and the ICH segmentation. So I'll attract your eyes here to this main graph to the upper right that displays stability edema volume against end of treatment edema volume. And you guys will see that we have the blue, which are medical patients, and the reds, all kind of grouped together here at the stability edema volume. So everyone kind of starts off with a similar edema volume and stability, but you'll see that the surgical patients on red generally have better end of treatment edema volumes. They're generally small overall, which is reflected by this less sharp slope, by this flattened slope compared to the medical group, which starts similar to the surgical group, but sees this vast increase in edema over the treatment period, which would corroborate the finding that ICH reduction is associated with reduction in edema, perihematomal edema. And the bottom left, you'll also kind of see a similar finding. We have ICH % removed at end of treatment, and then plotted against reduction in edema CC. And you'll see in blue we have the medical group, and red we have the surgical group. So you'll see that the surgical group, not only are they further along to the right of the x-axis, meaning that they have a higher percentage of ICH overall removed, but they're also higher on the y-axis in that they're having a larger reduction in edema. So this kind of reflects kind of why we do this, why you guys are part of the MISTIE 3 trial, you know, in that ICH reduction is associated with the reduction in edema. So this slide reflects the future of the reading center here. The future of segmentation of ICH, we believe, is going to be automated, but the research that we do here in the reading center will hopefully feed into that process and feed those working on these types of algorithms, and hopefully create a tool that you guys can use without a reading center. So here, this is essentially a project Pitch Perfect by Dan and Natalie, John Micheli, etc., that are attempting to use probability estimation using random forest on CTs to automatically segment primary intracranial hemorrhage, intracranial hemorrhage, and you can see a depiction of that here. So these are the references and the papers that I referenced in this presentation. Again, my name is Hassan. If you guys have any questions, you can call the Reading Center, or you can email me there, my email address, and I'll be happy to answer any questions or talk to you about what we do here and how I could help you with regards to any projects or ideas you guys may have. Does anyone have any questions? Okay, thanks guys. Nice talking to you.
Thank you, Hassan. All right, now on to Ryan and Tracy, dynamic duo.
Thank you, Amanda. All right, so we're going to go through, now that we have completed enrollment in the MISTIE 3 trial, that means that we're done, right? No more work to do. We can just, you know, forget about it and finally fall asleep in our operating rooms, but not quite. So, in general, there are, for our closeout procedures, we're generally seeing 3 groups of sites, and with slightly different procedures depending upon which group you may fall into. So, for sites with no, that didn't enroll any patients in the trial, you are pretty much done. You can please answer any regulatory queries that you see on your site documents tabs. You can close out your study with your IRB, and please upload that letter of IRB closure and a delegation of responsibility log with stop dates for all personnel corresponding to that date of IRB closure. For the other 2 groups, we are asking for other 2 groups, meaning any site that has ever enrolled a patient, whether or not you still have a patient in follow-up or not, we want you to keep your IRB open. This is because our data managers will be going through the MISTIE 3 data sets looking for any anomalous entries, and there may be data cleanup needs that continue well after, well, hopefully not too far after, but they're going to be on it so that we can get it cleaned up as fast as possible. But your IRB does need to remain open so that you can address any data queries that might pop up. As with the first group, please answer any regulatory queries that pop up in the coming months. I and our monitors will be doing in-depth reviews of all of the regulatory documentation at all sites, and we'll let you know what we need. For sites with patients still in the follow-up period, also be sure to keep up to date with your NIH stroke scale, modified Rankin scale, and outcomes trainings. The last thing we want to do is get complacent and end up with a situation where we have a patient coming in for a follow-up and nobody at your site is trained to or has their trainings current on that patient for your outcomes assessments. I want to make a special emphasis on to keep tabs on personnel accounting. Your 1572 and delegation of responsibility logs and their corresponding personnel tabs in the EDC need to be kept up to date through the closure of the trial at your site. And for the delegation log, that means we want to see all personnel ever involved with the trial at your site with appropriate start dates. In this case, sometimes you can now put stop dates on some of these personnel for team members like neurosurgical residents or people who are only responsible for giving a dose to surgical patients. Those personnel can probably be taken off the study at this point, and you can put stop dates on your paper log now and make that note in the EDC as well. For the FDA 1572, please make sure that in Section 6, any personnel at your site that have had a direct and significant contribution to the data have appeared in Section 6. This is all your sub-investigators. Some sites I know have not updated this form since the very beginning of the trial. And if you didn't need to, if you had the same team for the entirety of your participation in MISTIE 3, then that's fine. But I know a lot of sites have had some personnel turnover. So please make sure that your 1572 is also up to date.
Okay, so to continue on, this is Tracy. Good afternoon. To remind you that we did send you the letter to submit to your IRB that we are closed to enrollment. We are still deciding whether each site needs to upload that letter or not. But what every site would need to do is to upload the acknowledgement from the IRB, whether it's a return email from them or if they send you a letter or an automatic email, make it a PDF and upload that under, I think it's number
14, slot 14.
14.
There's a radio button on that slot that says acknowledgement of closure to enrollment.
Yeah.
Not closure of the entire study,
No.
just closure to enrollment.
Right. And if you could notify me, that would be really helpful because I have a whole procedure that I need to do once I know that you've done that. That's just a favor to me. So that's really what we need you to be looking for right now. Also, we want to make sure that the pharmacist that we have in the EDC is still your pharmacist, and we still have her correct his or her email addresses because our site pharmacist will be contacting them about how to destroy the drug and what documentation we need back from them. So also, continuing on with what Ryan was saying about the delegation laws and the EDC, we really need you to keep that current. We need to know who to contact there. If someone leaves, let me know. People will need to have EDC training so they can access the VISION database if your coordinator leaves, your lead coordinator, your backup coordinator, your PI. Everything is basically notify Tracy. I will be working on all the follow-up, and if you show the next slide, any changes in personnel, training that might be need to be done, any kind of general MISTIE 3 questions you have. And of course, don't follow the rule, I am here to help. So please feel free to contact me at any time. Thanks.
Actually, before we move on, does anyone have any questions about our?
No, I don't want to answer questions.
Tracy doesn't want to. Tracy's not taking any questions right now.
Email any questions to Tracy.
I lied. Don't annoy the Tracy person.
All right, with seeing no hands, you guys will be all experts at this. Oh, wait, I have one hand up. Glenda, do you want to type it in, or I can unmute you? I'm going to unmute you. I would like to unmute you.
But it's not working.
Oh, and her hand's down. Okay. Well, you guys know that we are here should any questions arise. All right, and now on to Christina.
Okay. Hi, guys. I'll be giving you the MTI M3 update. Okay, so as always, I've provided my contact information for those sites that have any samples that need to be shipped still. I should have reached out to you already, but if I have not, then please reach out to me. We are still continuing on with the premise-only study for MTI, so let's keep that going. Most of you have already done this, but if you do have any MTI M3 patients that have enrolled, please make sure you're uploading your sample tracking worksheets and marking that radio button on the EDC. And then these are our MTI M3 numbers up to date. You may notice that it's a little bit different from the last webinar's numbers, but that is because after further verification regarding the sample count, we found a couple of discrepancies. These numbers are corrected, and as you can see, we have still made our 100 goal mark. Yay. Yes. But we still want to keep going. So please, if you have any premise-only patients that are eligible for follow-up, then please try to collect those samples. And then these are our MTI M3 horse race. So we have UAB up front with 15, Hopkins with 10, Thomas Jefferson with 9, U Southampton with 8, and Rutgers with 8, and then Salford and UPenn both with 7. And as always, if you do enroll a patient into MTI M3, or in this case, the premise-only study, you'll get 3 bonus points for World Cup. And then on to our...
Oh, 1 second. I have a question.
Yes.
How do sites know if they have a premise-only patient?
Well, if you're an MTI M3 site to begin with, and you have not collected any samples for them, then they are still eligible for the premise-only study, because you can collect that at any time. It's just a one-time sample.
Did everybody hear that? Awesome. All right, thank you.
No problem. Yep. And then on to our World Cup August update. These are our last 3 enrollments, so great job to Cruces and UTSA and Washington. And then our top enrolling sites as of 2017, you can see a lot of people making the board here. A lot of sites. And then for our top enrolling sites overall, we have UTSA up front with 24, UAB following with 21, U New Mexico with 16, U of Southampton with 15, U Cincinnati and North Shore with 14, Hopkins and Rutgers with 13, and then WashU and UT Houston with 12. And then, as always, if anybody wants to give a webinar presentation, you will get 5 bonus points towards World Cup. And then, so we will be crowning our Hanley Cup champions once all of the points are in, but since we are still going for MTI M3 and all of the follow-ups, that is to come.
To be, yeah.
To be announced.
To be announced.
And keep attending the webinars.
Keep attending, yes, we will be continuing with webinars The trial's not, we've only closed enrollment. We have follow-ups, we have data entry, we have query resolution, we have webinars, we have premise. We have a long ways to go.
Right. So still time to go up in your standings. And then you can check your World Cup points on the EDC, and this is how to do so. All right, that's all from me.
All right, thank you. All right, does anyone have any questions? All right. Okay, well then we will see you guys. It's September already.
Yeah.
So we'll see you in October. All right, thank you guys.
Thank you.